All right, class, take your seats. Today, we are going to cover a topic many of you deal with on a daily basis: coding for morbid obesity. We've got a lot to get through, so Mr. IT Guy, if you'd please just make this happen.
My name is Jerome, sir. Sure thing, Professor.
That's a good lad. Remind me to tip you later. Now, as the BMI of 40 or greater is no longer the definitive factor in the definition and support of the diagnosis for morbid obesity, the following definitions represent the most current recommendations. Number 1. Extreme morbid obesity is the condition of persistent and uncontrollable weight gain, an excess of body fat or weight of 100 pounds over ideal body weight. That is a potential threat to life. As you can see, Mortimer is a little too passionate about his Gouda. Kidding. He's a stunt cartoon mouse. It's all prosthetic. Okay, where were we? Ah, yes. It is also defined as being sufficiently overweight so as to prevent normal activity or physiologic function, or to cause the onset of a pathologic condition, such as cardiac and endocrine disturbances, including coronary artery disease and diabetes mellitus, as well as some kinds of cancer and respiratory problems. 3. For surgical interventions, morbid obesity is characterized by a body mass index, or BMI, equal to or greater than 35 kilograms per meter squared, or a BMI of 35 or higher. In persons who have certain comorbid conditions, such as those mentioned in the second definition. Obesity is further classified according to the National Institutes of Health, NIH. Class 1 obesity equals BMI of 30 to 34.9 kilograms per meter squared. Class 2 obesity is a BMI of 35 to 39.9 kilograms per meter squared. And Class 3 or extreme obesity is equal to a BMI greater to or equal to 40 kilograms per meter squared. Providers must use one of these definitions or a combination of them when documenting morbid obesity in support of the disease, in addition to a statement about how it is a threat to life or has an effect upon patient activities or physiological functioning. When using the bariatric surgical guidelines, physicians must make it abundantly clear that the specific comorbid state that the patient has is directly related to the patient's obesity and is preventing the patient from normal physiologic function and normal activities. Difficulty with ADLs, activities of daily living, walking long distances, breathing, making the bed, etc., etc. Any progress note that uses the bariatric surgical guidelines must include a statement such as morbid obesity as evidenced by a BMI greater than or equal to 35, causing type 2 DM with angiopathy and as a result difficulty walking any distance or standing for long periods of time. Or morbid obesity as evidenced by a BMI greater to or equal to 35, causing coronary artery disease and pre-diabetic blood sugars at present. Excess body weight also interfering with ADLs secondary to breathing difficulties when patient bends down or tries to stand or lie down. Remember, BMI on its own no longer supports morbid obesity. So even for a BMI of greater to or equal to 40, you must document morbid obesity and a treatment plan in the impression and your progress note along with any comorbid conditions or activity issues caused by it. In the absence of the diagnosis and treatment plan, the Z code being reported for the BMI measure will be considered an unsupported diagnosis and will lead to RADV audit failure and refund issues. Now, let's give a hand to Mortimer. Marvelous performance, my friend. He'll be playing King Lear next month on the Cartoon Network. Won't want to miss that one. No animals were harmed in the creation of this MRA Minute. These links will take you to the ICD-10 CM guidelines, the 2017 crosswalk of codes to HCC and RxHCC categories, and to the most current listing of ICD-10 CM codes on the CMS site. Please feel free to muck about in them for clarification and further edification.